Hello, everyone. We're going to get started in just a minute here. We're going to allow some more people to get online. We still have a lot of folks trying to get in. So in the meantime, if you would be so kind, just put where you're from, where you're calling from in the chat so I can see where you are in the world. And then we'll just get started in just a minute or so. Okay, we're going to get started. Hello, everyone, and welcome, welcome, welcome. Thank you for joining us today. My name's Catherine Blackwell, and I am the Chief Health Equity Officer for the Allergy and Asthma Network. Wanted to just take a minute to say thank you so much for joining us. We are in for a real treat today with Dr. Ann Maitland as our today's presenter. Now, we have a few housekeeping rules before we start today's program. First, we're going to be muted for the webinar, and we're going to record today's webinar and post it on our website within a few days. And you'll be able to find all of our recorded webinars on our website at allergyasthmanetwork.org. And all you have to do is scroll down to the bottom, and you'll find our recorded webinars and any other upcoming webinars that you'd like to attend. This webinar is going to be about an hour, and that includes time for questions. And we're going to take those questions at the end of the webinar. But you can put your questions in the Q&A box at any time, and that Q&A box is located right down there at the bottom of your screen. So we're going to have somebody monitoring the chat if you have questions or you need some help. We're going to get to as many questions as we can before we conclude today's webinar. Now, this Advances webinar is in partnership with the American College of Allergy, Asthma, and Immunology. ACAAI offers CMEs for physicians and attendance credits for all others. And you can create a free ACAAI account and obtain CME or attendance credits through the member portal for Advances webinars. All attendees are going to be offered a certificate of attendance, and no other continuing education credit will be provided. A few days after the webinar, you're going to receive an email with additional information and a link to download the certificate of attendance. We're also going to try to add the link into the certificate in the chat. So let's get started. Today's topic is seasonal allergies, optimizing treatment for each patient. As many as 60 million Americans live with seasonal allergies. Tree pollen is active in the spring. Grasses and hay are active in the summer. And fall brings ragweed. Now, in this webinar, we're going to learn how to diagnose and treat your seasonal allergy patients. It is my esteemed pleasure to introduce our speaker, Dr. Ann Maitland. Dr. Maitland was named one of New York Times 2011 Super Doctors and one of America's top 21 women's doctors by LifeScript.com in 2009. She is a fellow of the American College of Allergy, Asthma, and Immunology, and a member of the American Academy of Allergy, Asthma, and Immunology. Dr. Maitland is very active in local societies and the surrounding communities to increase awareness of immune-mediated disorders. She's also involved with research to continually improve the treatment of allergies, asthma, and recurrent infections. Her clinical focus includes the diagnosis and treatment of allergic skin disorders, allergic rhinitis, hayfever, drug allergies, food allergies, sensitivities, asthma, and recurrent infections. Dr. Maitland, thank you so much for being with us today, and I'm going to turn it over to you now.
Well, I want to thank you again for this very kind invitation. And actually, if you can contact my brother, because he always wondered when I was going to get a real job. Just kidding. Anyway, absolute delight to talk about a condition that a lot of people describe as a nuisance, but I'm hoping to show you that this is actually more of a menacing condition that should be underestimated regarding what it can do to your vitality and wellness. So this again is the mission of the Allergy and Asthma Network in the need to end needless death and suffering associated with asthma, allergic conditions through outreach, education, advocacy, as well as research. This is me, and I'm currently the director for our allergy and immunology services at Metrodora Institute in Salt Lake City. But I also retain my assistant professorship at the Icahn School of Medicine in New York. These are my disclosures, and this has nothing to pertain to what we're going to talk about regarding the diagnosis and management of allergic rhinitis. And these will be the learning objectives, where we're going to be talking about the burden of allergic rhinitis, the unmet needs, especially on the individual basis, and then the need to create an individualized treatment plan for those that suffer with allergic rhinitis. And please understand, with climate change, it used to be April showers, May flowers. We now see individuals who suffer with either tree pollen starting in February, grass pollen starting at the beginning of June, and then ragweed and other weed sufferers are on also late fall trees until the first frost. So what is rhinitis? It's inflammation of the upper airway. So you're talking from the tip of the nose to the back of the throat and up the tubes that go to the inner ear. It's commonly referred to as allergies, but allergies just means you have inflammation that can impact any organ system. Allergic rhinitis focuses on the fact that you're making inappropriate immune responses, taking away from how your body functions to send inappropriate energy to fight against things that are completely innocent. And they have a tendency to cause the following symptoms. You have the sneezing fits, runny nose, itchy eyes and itchy throat, ear fullness and pain, susceptibility to sinus headaches and throat pain as well, nasal congestion, and also that infamous postnasal drip, often called posterior rhinorrhea. And you wonder, if this condition is so common, why isn't it considered more menacing? And I want to point out why that might be the case. When you have ongoing upper airway inflammation, it really can impact your quality of life, but also impact other comorbid disorders that are quite common, including individuals that may have hypertension, susceptibility to sleep disorders. And I will show you that this is an extremely prevalent condition where when I first entered into clinical practice, less than, I would say, 10% of the population were impacted by having a positive allergy test. The latest assessment shows that 1 out of 3 adults are impacted by allergic conditions, including over 25% having seasonal allergy. And as was previously stated, close to 60 million Americans, both children, adults, and a forgotten population, seniors, suffer with this chronic upper airway inflammation. So to the point now that we estimate anywhere to 40% of the population are affected. And this is actually an article from Time magazine back in the early 1990s showing that this epidemic was just starting to get on the rise. So in many ways, having allergic rhinitis is nothing to sneeze at. Up to 30% of adults, up to 40% of children. And if you ask the patients who are dealing with these symptoms, nearly 60% of them report that their symptoms are moderate or severe, meaning it's actually interfering with other aspects of their life, whether you're talking about participation in school, participation in work, or frankly, missing time in the form of absenteeism as well. Interestingly enough, for employers and schools, is the second leading cause of chronic disease in the United States. And again, now up to 60 million persons are affected, and nearly half of them have had these symptoms for more than 10 years. So you can imagine how spring doesn't bring joy, but suffering in the form of upper airway inflammation that can also impact other organ systems. Some of the conditions that commonly travel with allergic rhinitis are sleep disorders, very difficult, including snoring, increased susceptibility to infections, whether you're talking inner ear infections, throat infections, or sinus infections, It can cause you to have cough from postnasal drip or cough that's associated with asthma. Interestingly enough, nearly 80% of patients who have asthma have upper airway inflammation with a seasonal component. And then you have individuals that are susceptible to vertigo. And if you've ever had this condition, you know how devastating it is to just have your world spin every time you move. One thing that maybe a lot of even primary care might not appreciate is how having chronic upper airway inflammation contributes to neuropsychiatric illnesses such as mood disorders, including depression and anxiety, as well as neurodevelopmental disorders. It's not uncommon for children to have issues with attention deficit because they're not sleeping well. The ongoing inflammation can actually impact how the brain functions as well. So those are the indirect costs that are associated with having not well-controlled rhinitis. The direct costs is astronomical. We're talking hundreds of millions of dollars a year that's being lost, not only in treatments that may not be as effective as they should be, but also ending up in the emergency department or frequent visits to your doctor because now you're getting recurrent sinus infections or asthma exacerbations. And the latest illness on the block is eosinophilic esophagitis, which is associated with inflammation impacting the upper GI tract. And we have actually some individuals who are at even risk for having seasonal allergic rhinitis associated with anaphylaxis. But very common symptoms is not only ocular issues. Can you imagine trying to drive when you're having all this inflammation causing you to have itch or swelling, fatigue, as well as asthma exacerbations? And this is just again to highlight that in addition to other disorders that are known to prevent people from participating in work fully, including diabetes or hypertension, allergic rhinitis is second in causing lost productivity at work. So as you can see, this so-called nuisance of a disorder actually is quite menacing in that it causes quite a few problems. Oops. So it's prevalent, it causes a lot of disorders, and it contributes to other disorders, but only 1 out of 8 individuals that are impacted by chronic rhinitis have these issues. Talk to their doctor about trying to improve the symptomatology that's associated with having chronic upper airway inflammation. And the reason for that is many times people don't think you need a medical home for this chronic disorder, but that is definitely the case. And I'd like to kind of drill down a little bit more about the need to present this to your primary care, the primary care to recognize that this is a condition that might need specialist attention. And then for the specialist to be very thoughtful and mindful about educating you on how to improve therapies that may get these symptoms under control. So let's talk about delayed diagnosis and management of seasonal allergic rhinitis when it comes to the patient, when it comes to the general practitioner, and then when it comes to the specialist. So when it comes to the patient, a lot of patients don't know that they should even present it to their pediatrician or their general practitioner. One thing I like to point out is many women rely on their gynecologist for their primary care, but realize that's not the focus of a gynecologist. I do strongly recommend that women should align themselves with a person who is trained and has much experience in adult medicine beyond the exposures, beyond the training of a gynecologist. So a family physician, an internist would be a lot more helpful in providing a medical home to get these conditions under control. And because patients don't think that they can present it, they end up trying to self-manage with over-the-counter medications, including decongestants. And there's a reason why decongestants are behind the counter. They have a tendency to raise blood pressure, can be misused in the form of illicit use, and can drive hypertension and make other disorders much worse. And another reason why patients might not bring attention to their doctor, they might not want to take time away from work or school. They might not want to pay the copay. They just don't want to make that investment. But that investment might be very necessary for not only improving your upper respiratory health, but also improving your mental health, improving your lung health, and potentially contributions to other disorders that you might be dealing with, including hypertension, diabetes, or other inflammatory disorders. And I'd like to also point out, it's really important if you have nasal congestion, if you have sleep disorders, if you have the diagnosis of asthma, you should be tested to see whether or not you have an allergic component, because there's some really good therapies that are available that if you get the rhinitis under control, you will reduce your susceptibility to these other disorders, including neuropsychiatric illnesses. So let's move over to the general practitioner. Again, a lot of patients don't believe that a general practitioner would be open to discussing how to treat this. And also and the way this is taught in training, whether you're talking family medicine, pediatrics, or internal medicine, maybe not enough attention is given to the need to screen for this disorder and then educate patients on how it can contribute to other conditions besides the typical nasal congestion or postnasal drip. And again, just like the patient might not know that these other comorbid disorders run with allergic rhinitis, it's very possible that the family medicine practitioner, the internist, or the pediatrician doesn't know the association, for instance, for pediatrics, that having not well-controlled rhinitis can contribute to attention deficit disorder or mood disorders. Or the internist might not recognize that not well-controlled upper airway inflammation contributes to sleep disorders or fatigue. So if you have these other conditions, you should be screened for upper airway inflammation, and then you should be screened to see whether or not there's a seasonal component. So let's move over to the primary care, making the appropriate referral. So if you have ongoing upper airway inflammation, you go to an ENT specialist, often also referred to as an otorhinolaryngologist, or do you go to an allergy immunology specialist? And I want to just break down the two different specialists' approach. They're definitely overlapping, but there are also some key differences to appreciate. Regarding the ear, nose, and throat specialists, they have the ability to directly visualize not only the anterior aspect or the front part of the nose, but also the back part of the nose called the pharynx, as well as the lower aspect of the throat, even down to the vocal cords. Then if they see that you have inflammation that's suggestive of an allergic component, they might make recommendations and prescribe over the antihistamines, where we have first generation antihistamines that work better and dry out the mucus, but have a tendency to make you sleepy. So then they made second generation antihistamines like loratadine and cetirizine, which are less likely to make you sleepy, but can also last 24 hours. But I have to tell you, straight antihistamines don't take care of the major presentation in individuals that have not well-controlled allergic rhinitis. And that is the congestion. So that's why it gets teamed up with medications that are decongestants. And if you have diabetes, if you have hypertension, if you've had a history of stroke, or have had a history of heart abnormal cardiac rhythms, you cannot take these medications because you're going to trade in one problem for another. One other thing that the ENTs can do, but may not be a very common procedure, would be actually called a radiofrequency ablation, where they basically scar down the tissue so it's less likely to become inflamed. But that technique hasn't really taken suit in a lot of ENT specialist practices. And also, they might not necessarily order the tests that are necessary to identify what you might be having allergic inflammation to regarding common environmental allergens. So I'd like to pivot to what allergy immunology specialists have been doing for 100 years. And finally, in 1989, we had a biological basis for why those positive skin tests were causing problems. Doing the skin testing or blood testing, we're looking for an antibody called immunoglobulin E, or IgE, that prior to the allergy epidemic actually was the antibody that was used to detect and fight off parasites. And outside of industrialized nations, there's a huge burden of parasites that contribute to illness in individuals that don't have protected water or protected food or sanitation that picks up their refuse every Tuesdays and Thursdays. So the allergists have the ability to do the skin testing, whether you're talking drops on the skin or a minute amount being injected in the skin. And I have to tell you, I prefer doing the allergy testing because then I can show you every time you breathe in this substance, this is what's happening on your respiratory linings. This is what happens when you have the cat sleep in the room with you. This is what happens when you decide to cut the grass. This is what happens when you start to dust and don't use a vacuum that has a HEPA filter, or you're not wearing a mask. So that type of inflammation will flare up. And I can tell you, if you have allergic inflammation, it reduces a non-allergic trigger like airborne chemicals from perfumes or personal toiletries or cleaning agents to make your congestion or your symptoms associated with rhinitis worse. So the allergist will have the opportunity to tell the difference between someone who has an allergic component, meaning your body has made this antibody, and every time it sees it, it's going to cause it's going to increase the amount of inflammation that's going to be recruited to the airways, as opposed to a non-allergic component. And I also like to for those that work in an environment where they're constantly exposed to airborne antigens, such as if you're working in the nail industry or cosmetologists, or if you're working as in maintenance, or if you are working in outdoor, running a nursery, you're at increased risk for being exposed to both irritants that can prompt you the developing an allergic component. And the allergic component would then allow these non-allergic components to make your congestion even worse, much more easily. So I find that allergists have a tendency to not only identify what you're allergic to through skin testing or blood testing, they also will make an effort to educate you on how to use methods to reduce your exposures in your environment, how to use your medications, and then if your medications are not available for you, or you might not find that the medications are working for you, it might be important to think about allergen immunotherapy, which I'll get to. I have to tell you that there's a huge issue about having access to allergy immunology specialists. First of all, when it comes to medical schools and nursing schools, less than a month, the first year of graduate education is focused on allergy and immunology education. In this country, there's only one allergy immunology specialist for 100,000 residents. And that's a problem if you have 60 million people impacted by this condition. And then also there's limited opportunities. There's only 80 training programs in the country, which means that there's very few allergy immunology specialists that are available. And also general practitioners, internists, surgeons don't get enough exposure to understanding the basis of this chronic condition and how to get it under control. So, and this is a statement that was made back in 2007, that there's just not good allergy immunology management and practices, hospitals, clinics. It's actually minimal or non-existent, which is a huge issue. And just to give you an idea, this is trying to identify an allergy immunology specialist, not only in urban centers, where I can tell you, for instance, in one of the communities in Manhattan, where there's over 250,000 people living, there's not a single allergist between 98th Street and 168th Street east to west. And then you can look at this map, and depending, the darker brown color shows that you have an a huge number of allergy immunology specialists. But as the color gets lighter, these are individuals that may have to drive up to 50 to 100 miles in order to get an evaluation by an allergy immunology specialist. So we have to do a better job in educating our general practitioners and other specialists on the recognition of allergic rhinitis and comorbid disorders, but we also need to educate the general population that this is not a condition that you need to just live with and actually acclimate down to, but there's an opportunity to make you feel better. So what's up with the specialists? Besides not enough of us around, many of them have a tendency to just focus on the 3-minute visit in order to be able to keep their clinic open. And I have to tell you, as a former practitioner, where I was seeing close to 20 to 25 patients a day, it's the patient story. We do the allergy testing. Do you want allergy shots, and repeat? But there's more to it. And I think sometimes you might need a number of visits just to get the appropriate testing, try the recommended therapies, get a written action plan on how you should use those therapies, and then come back in a few weeks to a few months to say, is this working for you or not? So in many ways is secure the diagnosis, get therapies, and then see if those therapies work for you and you're not having any adverse reactions. And I would have to tell you, this is what we use in our practices. We have a tendency to use allergy action plans, but that's after I try to understand how well controlled or not well controlled your allergic rhinitis is. If you're just having upper airway symptoms that just come and go less than 4 days a week, less than 4 consecutive weeks, it's called intermittent, where you can just get away with avoidance measures and possibly using oral antihistamines. But if it's more persistent, meaning you're having, like, we're now in the middle of ragweed season. If you're having nasal congestion, post-nasal drip, itchy eyes every day for a few weeks, you're now into persistent. And now the question is it mild persistence such that you're able to go to school and work and pay attention? You're not having any sleep issues. You're able to participate in your activities. It's not triggering your asthma exacerbations. Now considered mild persistent, where you might warrant the use of a nasal corticosteroid. And there are plenty of them over the counter as well as prescription, such as fluticasone, mometasone, or triamcinolone. And there's also nasal antihistamines, which I find to be a lot more effective in controlling the congestion symptoms compared to the oral antihistamines. And over the counter, you now have azolastine, but prescription, you have olopatadine as well as azolastine. And now they have combination sprays where you get the benefit of the nasal corticosteroids. The nasal corticosteroids can take up to a week to start working, but the nasal antihistamines, such as the azolastine and olopatadine, start working in 15 minutes and work 12 hours. So having those sprays together in one medication, you can actually potentially use them as needed, which will you'll have a better chance to get the symptoms under better control. Other medications to be considered are leukotriene antagonists, such as montelukast and zofrolukast. And if the oral medications, the avoidance measures, and nasal preparations don't work for you, you have the opportunity of considering allergen immunotherapy. So this is the action plan that I typically provide, or representative of a typical allergy action plan, where we identify what you're allergic to. We let you know how to use the medication. And I have to tell you, a lot of patients don't use the medication properly. A lot of people have been taught this technique of going like this and like this. I just tell people, lean down a little bit and aim the spray at 1 o'clock and 11 o'clock. And you want to make sure you aim away from the nasal septum so you don't cause bleeding. And you don't need to stick the nozzle way up your nose. You can just, the spray is easily 3 to 4 inches high. It'll make its way up there. There are oral antihistamines. Again, you have the more sedating ones like diphenhydramine or chlorpheniramine. You have the less sedating ones such as levocetirizine, fexofenadine, as well as loratadine or desloratadine. You have the leukotriene antagonists. I have to tell you, the one thing I have a tendency to lean on the most is nasal saline. There are plenty of preparations over the counter. You can do your own DIY version, but literally just washing your nose out at night is a good way to reduce the inflammation that gets recruited in after you've been breathing 18 times per minute throughout the day in a pollen-filled environment, or mold, actually, because mold can also cause seasonal allergic rhinitis as well. And one tip to show that whether you are pollen allergic or mold allergic, is pollen is worse when the day is sunny and the wind is kicking up a little bit. Mold kicks up after rain. And one of the major mold allergens to be concerned about is alternaria, which we often call blitzkrieg rhinitis as well as blitzkrieg asthma. So, and some individuals will have problems when the day is nice, and some people will have problems when the day is wet. And then some unfortunate individuals have it twice daily. So we're going to start off with avoidance measures. We'll lean into a little bit more about the medications, and then we'll talk about other therapies, especially the use of allergen immunotherapy. So avoidance measures. Believe it or not, the COVID pandemic not only helped individuals reduce their exposure to breathing in SARS-CoV-2 to cause a viral infection, it actually helped control a lot of asthmatics and allergic rhinitis patients, because those masks, even a surgical mask, is very good at keeping out mold as well as pollen. So In addition, we already spoke about nasal saline. Just wash it out, because after you breathe it in, if you use the nasal saline, it's less likely to recruit an inflammation. Use of surgical masks are sufficient to reduce exposures. We close your windows when you're driving. I know it's kind of, a lot of fun driving with your car top down, but guess what you're breathing in? All that pollen that's settling in those, especially if you're out west or down south, it's almost pollen clouds that you're breathing in. You can use these filter guards if you have the windows that go up, and this will prevent, you'll get a nice breeze without the pollen coming in, so you don't end up sleeping with the enemy. It's a good idea, actually, if you've been outside either exercising or walking, to take a shower and wash that off so it doesn't land in your hair, and then you transfer it to your pillow. And then also using air conditioning. And it's really important that you have appropriate filters in the air conditioning unit so you're not kicking out pollen and mold that has accumulated over time. So these are just the general recommendations for how to do avoidance measures. Again, keep your windows closed or use air conditioning. Try to stay indoors as much as possible, or if you're going to go outside, wear a hat that prevents it from landing on your hair, and wear a mask. Let somebody cut the grass who doesn't have seasonal allergies, or at least, and hopefully they're wearing a mask when they're doing it. Consider vacationing like by the beach, where you have less likely to, the salt air will help be a natural rinse of your upper airway. And then when traveling by car, it's really important to keep your windows closed and use air conditioning. Let's talk about the medications that are available. So you really want to time, and this is the advantage of identifying what you're allergic to. This is an old calendar talking about when tree pollen starts popping up, and really you can even say some people are now suffering since we no longer have a white Christmas. I know that Christmas Day a few years ago, it was beautiful and balmy, and people were feeling it from the pine trees that they would bring in for Christmas. And tree pollen is active from February till about June. We have grass pollen that kicks up end of April, early May, and continues to the first frost. Ragweed is now, along with other weeds such as mugwort. And just to let you know, some individuals who have pollen allergies also have problems with fresh fruits and vegetables. So individuals that have tree pollen allergies will have problems with like cherries and peaches and apples. People who have grass allergy will have possibly problems with watermelon. That'll cause itch with fresh fruit and vegetables. But if you cook it, less likely to have that type of reaction. And then ragweed cross reacts with, for instance, chamomile. And then you have the year-round allergens such as dust mite and animal dander, as well as mold, again, which mold will kick up when it's raining outside. This is just to show you, if you're using medications and you have tree and grass allergy, you're going to be wed to these medications for 6 months, starting in February and then going all the way through the summer. Or if you have grass allergy, you're done from like April until September or October. So it's really important to know when you should start your medications. The nasal steroids, like fluticasone or mometasone, need to start at least a week before your season. Antihistamines are used as needed, but again, they don't do very good for congestion issues. Nasal antihistamines can be used as needed. They work in 15 minutes and last 12 hours. And the combination nasal sprays I would advocate are probably the best when it comes to topical medications and keeping not only the itch under control, but the congestion as well. So what I wanted to show you is that it's not the easiest thing even to take a vitamin on a daily basis. So taking an oral antihistamine, taking a leukotriene antagonist, and doing a nasal spray every day is difficult. And this is a study that shows that individuals that were given the diagnosis of rhinitis, given medications, less than 10% of them were using the sprays correctly. So they weren't getting the full benefit of the medication. So they're paying for the product, they got the prescription or went and bought it, and now they're not getting optimal relief. The other thing they found is that the predictors for individuals that were not very good at rhinitis control, and I will raise my hand as a working mother who makes sure everybody else is taken care of, and then I think about myself. But by that time, I'm too tired at night to do what I need to do besides just use the nasal saline right before I brush my teeth. Also, individuals that have active asthma have a tendency not to focus on keeping their upper airway under control. And then a lot of individuals have a tendency to depend on intranasal decongestants like oxymetazoline, which can be used up to 1 or 2 days. But then after that, you can end up with now a chronic rhinitis condition due to addiction to the medication that was meant to help clear the symptoms up in the first place. So how do we get your seasonal allergic rhinitis under control? And it really is a personalized decision on, once you get the diagnosis, understand what you're allergic to, let's see what you can use given what fits your lifestyle, which is going to be effective and not cause many side effects that are associated with it. So again, I want to emphasize that over the past decade, climate change has led to increased pollen release. So now not only the pollen counts starting earlier in the year, they're much higher. So people are terribly symptomatic with changes of seasons. And then also it means that you're going to be wed to some type of therapy, including, again, the oral antihistamines. Some people use vitamin supplements such as vitamin C or vitamin D or omega-3, or using nasal saline or antihistamines. And that costs a lot of money. You're talking about, just from the copays from 3 different medications, you're talking $100 a month. So what is another option? And I want to talk about the 3 forms of allergen immunotherapy. So we have what's been done for over a decade, over a century, is allergy shots. That requires you going into the office and being monitored. We have allergy tablets, for which we have at least 4 allergens that are prescription, including grasses, dust mites, as well as ragweed. And then we have allergy drops, and I just want to lean into that a little bit. So let's talk about allergy shots. The pros is it's been done for over a century. We know how much to give you, how long to give you. We can give you multiple allergens, both the seasonal allergens, such as the pollens, and the perennial allergens, such as the molds and animal dander and components of dust. We know that it reduces the risk for developing other hypersensitivity disorders such as asthma, and it's actually been shown to help with even atopic dermatitis or allergic eczema. And once you complete a 3-year course, they showed that the efficacy of the allergy shots can last 10 years. The downsides are you have upfront costs. You have to go into the doctor's office. You have to pay the copay, in addition to the copays that you're paying for the medications that are helping keeping your symptoms under control. But in many ways, I would urge you to think about investing in yourself, because not only do the allergy shots address the allergens you're sensitive to, it also reduces the risk of you developing sensitivities to other airborne environmental allergens as well. It requires time. You have to take time from work or school. You have to go into a doctor's office who knows how to administer the serums and recognize whether or not you might have the thing that I'm most worried about, you having a reaction besides a local reaction at the site of the injection, including anaphylaxis, meaning I give you a shot and you start clearing your throat. That is a grade 1 anaphylactic event and needs to be treated. So I already talked about the pros and cons of allergy shots. Let me talk about allergy tablets. Right now we have allergy tablets. It's the standard dose for both ragweed, grass pollen, as well as the 2 dust mites. It can be taken at home. There's no needles or injections. There's a lower risk of anaphylaxis. And no need for you to go to a doctor's office, sit there for 30 minutes, and then return back to your normal activities. The cons are you can only do 1 allergen tablet at a time. There's some individuals that will do 2 at a time, but I'm reluctant to do that because if you have a reaction, I don't know what had done it. Again, we don't know the long-term safety. We know that it helps reduce symptoms, reduces your dependence on medications. However, we don't know whether or not once you stop, there's long-term therapy available. The first time you get the tablet, you do it in the office because there is a risk of an allergic reaction such as anaphylaxis. So everyone is prescribed an epinephrine autoinjector. And welcome to the battle of the century, getting insurance companies to pay for this type of immunotherapy. And the one thing I might have mentioned before, I had one patient who I started on the allergy tablets, young boy, and within 2 weeks of it, he started complaining of irritation in his throat, which identified that he actually had eosinophilic esophagitis, so that medication had to be stopped. So the last form of immunotherapy I like to talk about is sublingual immunotherapy. These are drops that really hasn't been embraced in the United States, except for in some pockets, but it's been frequently used in Canada, Europe, as well as the Southern Americas. It doesn't require injections. It does not require an epinephrine autoinjector. It can be taken at home. I usually prescribe it. As a matter of fact, my practice is predominantly sublingual drops. It's put underneath your tongue, where you do 1 drop in the morning, 2 drops in the evening. It's been shown to reduce the need for daily medications, especially you could do it pre-seasonally and in the season or year-round. It can be used in children as young as 5 years of age. And it again helps reduce the dependence of other medications such as the nasal corticosteroids and the antihistamines and leukotriene modifiers. But what we don't know is if you stop the drops, how long does that therapeutic benefit last? We don't know the impact on other conditions such as atopic dermatitis or asthma. We know that it helps reduce the risk of asthma exacerbations in season when you're taking the drops, but we don't know if you discontinue after taking the drops for 2 years, how long does that therapy last? And we don't know the efficacy. The efficacy is very clear with some of these antigens, such as pollens, but we're not as sure as how effective they are for mold. So to kind of sum up, I would lean into the argument that allergic rhinitis is a menace, with now close to a quarter of the population impacted by seasonal allergic rhinitis. We know that not only does it cause upper airway symptoms and ocular symptoms such as itchy eyes and conjunctivitis, can increase your risk for infections and headache disorders, contribute to sleep disorders as well. It's also associated with neuropsychiatric illnesses, including mood issues as well as attention deficit disorders. And it's a major contributor to absenteeism at school and work, as well as presenteeism, meaning you're at work, but you can't focus because your nose and sinuses are just awry. We see that the issue when it comes to poorly controlled rhinitis is that patients have a tendency not to tell, don't think that this might be a problem. So they try to self-medicate or just suffer through. And then a lot of doctors don't necessarily pay attention to the fact that rhinitis may be contributing to other things, or it actually is quite bothersome. I can tell you, I had a minister come through and his wife called me saying that my husband was suffering. And one of the nurses I was speaking to is she's saying, how you can suffer from cancer. I'm like, you can suffer from rhinitis. This is his livelihood. He wants to be able to speak clearly. He doesn't want to have risk of vertigo. He doesn't want to have risk of an asthma exacerbations or sinus infections. This interferes with his livelihood, and we have to lean into that. So you have to make sure that the healthcare provider practitioner is also listening to your concerns as well. And then refers you out so you can secure the diagnosis of whether you have allergic rhinitis, non-allergic rhinitis, or both, and then write out a therapy plan that works for you. So better health really requires for this chronic condition a patient-practitioner partnership for optimal rhinitis care. It starts with identifying a practitioner who's going to listen to you, starting with your general practitioner, pediatrician, family medicine specialist, or internist. And for the ladies, your OBGYN specialist. And then they need to assess you. And there's a very straightforward questionnaire, 5 questions to identify whether or not you have any issues. Here it is. And you answer these questions while you're waiting in the office to be brought back in. And if you answer any of these questions, you now need, as a positive, it warrants an evaluation, whether you're going to get the blood test or the allergy skin testing. And I have to tell you, the blood testing is twice as much per allergen than skin testing. Skin testing, you get the answer in less than a few minutes. Blood tests It has to go to the lab, they have to run the test and come back, and like I said, it's a lot more expensive. So you can understand why some insurance companies might not want to pay for but so many allergens to be tested. The primary care also should have this questionnaire available, especially if you have patients that have sleep disorders, have evidence of asthma, sinus infection, food allergies, is having ear fullness and pain or vertigo, or susceptible to developing polyps. And then the medical practitioner, again, needs to emphasize, I can't tell you, I gave a lecture many years ago. This little boy was being restricted to special ed because he had behavioral issues. Turns out his adenoids and his tonsils were enlarged, contributing to a sleep disorder. Once he had his tonsils and adenoids removed and he was maintaining a regimen for his rhinitis, he was able to rejoin a normal class. So his attention deficit disorder came under better control. Again, you want an accurate diagnosis, the best set of working diagnoses, so that you then get the optimal therapy. Can you get away with just avoidance? Do you need oral antihistamines? Do we need to step up to nasal corticosteroids or a combination spray of antihistamines as well as corticosteroids? Shall we add on a leukotriene antagonist that helps with the upper and the lower airway? And if all of these are ineffective, costly, or having side effects, or you want to be able to prevent the development of other disorders, allergen immunotherapy should be considered. So that's the action plan again, readily available. You can even download it and bring it to your primary care or your general practitioner, who should then refer you out to a specialist. So you can get the avoidance measures, get an ordered plan of the medications, and possibly consider allergen immunotherapy. It all starts on educating yourself about this chronic condition that's quite prevalent, educating your general practitioner, who may not necessarily know that this is something that would be important not only for you, but other patients in the practice, and then partnering with a specialist that understands the impact of rhinitis on one's health and wellness. So tackling the burden really requires patient-partner partnership. And I'm going to end the conversation here and welcome any questions. And again, thank you for the opportunity for participating in this webinar by the Asthma and Allergy Network.
Thank you, Dr. Maitland. Wow, that was a great presentation, a lot of information. There are a couple of questions, and I'm going to do my best to try to combine it. I think you kind of already addressed the one, because someone asked about allergy shots and the allergy medication and how insurance friendly they are. So you want to just speak to that?
So I would say that would be a great conversation with your, so ear, nose, and throat physicians don't typically do allergy shots, so it normally falls under allergy immunology. It would be important for you to have a conversation with an allergist that's in network, and they'll be able to analyze whether or not you'll be able to go on to allergy shots. They have a tendency, most insurances have a tendency to limit your testing, but they typically will the first year they know it's a buildup where that's more frequent visits, so usually 20 to 26 weeks. But then they're more than happy for you to go on a set of injections once a month, because now you pay that copay once a month and you're not taking 3 medications to control your symptoms that weren't helping you get your symptoms under control in the first place. So again, leaning into that patient practitioner partnership, that is a conversation that you need to have with a practitioner who understands your condition, knows how to listen to you, and then translate that into meaningful action to get your symptoms under control.
Okay. And then there was another question about, if you have allergic rhinitis, are there certain foods that you should avoid? And there was one comment that the majority of people that the person encountered have had fewer or milder symptoms when they switch to a very low carb diet. So do you have any commentary about that?
So a low carb diet usually goes with using vegetables that have vitamin C in it. So vitamin C has a tendency to be very good at stabilizing mast cells. And then there are other nutraceuticals that can be very helpful for that as well, that can be obtained from food. Also, carbohydrates getting away from carbohydrates also means you're at better risk of not having issues with diabetes, which is not good for anyone who has inflammatory issues. And you also staying away from carbohydrates reduces the risk of you having an increased BMI, so becoming heavier. The more fat you have on your body, the more likely you're going to have an allergic type reaction to these antigens. It's not a good combination.
Yeah.
And so I think it's depending on how you change your diet, leaning into more fruits and vegetables, the vitamin C can be very, very helpful. And also leaning away from foods that will increase your susceptibility to developing diabetes, as well as becoming more heavy and fat.
Okay. Is there any correlation between vertigo and allergic rhinitis?
Yeah, so if you have, so there is a tube from your inner ear that goes to the top of your throat. And so any inflammation up there, like if you've ever been on a plane and then you swallow, you pop your ears, that's the eustachian tube that connects directly to your nose and back of your sinuses. And so that when you breathe in stuff, that inflammation will involve all of the upper airway, including the eustachian tube. So not only is there a link to vertigo, there's also a link to, for instance, children that keep on getting recurrent inner ear infections, or children who end up and adults that end up with enlarged adenoids and tonsils that can contribute to sleep disorders. So there's plenty of reasons. If you're popping your ears are itching, that's because you've been breathing in an antigen like mold or pollen or dust that's getting up there, and that tube gets blocked. And then the fluid gets trapped in there. And now that very special apparatus that's responsible for maintaining your balance is not able to equilibrate properly. And then you're going to end up with either ringing in the ears, which is called tinnitus or tinnitus, depending on how high up you are on I-95 between Massachusetts and New York, or vertigo or dizziness as well.
Right. Okay. Thank you. We have a school nurse on the line, and she sees a lot of students with allergy symptoms, and she asked if you have any recommendations for allergy management in a school setting.
So, well, one, you want to make sure that the classrooms keep those windows closed during those spring and summer days. That's one, or have the air conditioning on, and some schools can't afford to do that. I think also it's really important that was identified a long time ago is you want to make sure those school buses aren't not parked up right against the building and those fumes are getting in, because that will aggravate the allergic rhinitis as well. I would let the parent aside. I would pull the parent aside saying, hey, Jamie is doing the allergic salute and going like this. That's a sign that they should probably go to the pediatrician and get a plan to get their symptoms under control. A lot of parents sometimes don't necessarily want to spend the money to go for a doctor's visit and will rely with over-the-counter. If they're going to start using over-the-counter medications, they should understand if the child does not get any better taking whatever prescription or over-the-counter antihistamine, it's not going to work, and they shouldn't double it, right? They shouldn't double the amount of loratadine, or they shouldn't double the amount of fexofenadine. They should go to the doctor and get a better plan and invest in that office visit so that they get a written out plan on what to take for what. For instance, oral antihistamines does nothing for itchy, watery eyes. You have to use a drop. Or use a nasal corticosteroid spray that's being used properly in the children. And sometimes just pointing it out to the parents saying, hey, this is happening every time he goes out or she goes out to the playground. She comes back worse. I think she has seasonal allergies, and bringing it to the parents' attention. So the parents are now educated out of their busy schedule to make the time to go to the pediatrician or potentially schedule to see an allergy immunology specialist or otolaryngologist.
Okay. And then one other question, they asked if a blood test, is it as effective as skin testing? And does it test for multiple allergens?
So there are pluses and minuses. It's not as sensitive as one form of skin testing. Okay, so there's two forms of skin testing. There's the prick test and then the injection. And yes, you can test for a lot of that, but I can tell you insurance companies prefer to pay for the allergy testing because the allergy testing is a lot less expensive. So the average blood test can be anywhere from $7 to $12. And if you do a panel of 30 or 40 allergens, you're gonna run up a bill. And insurance may or may not cover all of those allergens that are being tested. And then also there are false negatives with those tests. And so you won't miss it. Are there some conditions that I'll lean into a blood test as opposed to a skin test? Yes. If you have bad eczema or you can't stop your antihistamines so I can get appropriate tests, then I'll go to a blood test. But for the most part, I think it's a good educational tool for the parents to see, for instance, or the patient to see, the adult patients to see is like, if you're going to keep, Kitty in the bed with you, or you're going to, go walking at, the height of pollen flying around, which is between 7 and 10 a.m. in the morning and 4 and 7 p.m. at night, you're going to be breathing this in, you're going to be a lot more symptomatic. So there's ways of giving guidance for avoidance measures also, both for the blood tests and the skin testing. But I think skin testing is more expensive. I think there are false negatives. And then sometimes whoever orders the test, because it might be a primary care, they might not necessarily understand how to interpret those tests.
We have time for one more question, and someone asked, what age is it okay to take a decongestant?
In my opinion, never.
Yeah, I understand.
So the reason why I say that, all right, so if most people don't know this, the reason why they put certain decongestants behind the counter is because they were made into amphetamines. Okay, so if anybody saw Breaking Bad, that's what they were using. Okay, that medication is not very good for you. So every once in a while, it's fine, but you want to make sure you don't have a history of stroke. You want to make sure you don't have a history of an arrhythmia. You want to make sure you don't have a history of hypertension, because that can make things worse. Period. And then also for women in childbearing years, that decongestant ain't good for the baby. So I would prefer that you use medications that are safer, especially when a lot of people are running around with conditions that they don't know. And then I can tell you the nasal decongestants, you can only use them for 1 or 2 days. I can't tell you how many patients have to go on a 12-step down procedure to get off of their addiction to the nasal decongestants. You end up causing another problem. So if you are going to use the decongestants, be very mindful that you put yourself at risk. If you're going to use a decongestant, I would use the one that's not behind the counter, because it's less likely to be so stimulating. And that's another thing, it'll interfere with your sleep. Like taking 120 milligrams or 240 milligrams of pseudoephedrine, it's crazy. Your blood pressure is going to be like, and then the nasal decongestant, do the saline, use the nasal decongestant. You can use it up to 1 or 2 days, but then after that, you need to stop. Otherwise, you're going to be one that has a bottle on both sides of the bedstands, in your car, in your purse.
Yeah, I understand. Okay. Well, Dr. Maitland, we are at the top of the hour. Thank you so much. This has been so informative. We have a few webinars coming up in September. First up is updates on atopic dermatitis treatment options and the role of biologics, presented by Dr. Peck Ang on September 18th at 12 p.m. Eastern Standard Time. Then we'll welcome Melissa Page from the National Association for Medication Access and Patient Advocacy to discuss their new Medication Access Coordinator training program on September 24th at noon Eastern Standard Time. You're going to receive an email for Zoom in a few days with a link to the recording and an evaluation and supplemental resources. So thank you again for attending from all of us at Allergy and Asthma Network, and join us as we work every day to breathe better together. Thank you very much. Have a good afternoon. Bye-bye.